Okay, anyway, welcome everyone to Friday Lifetime Teaching. Thank you for joining. If anybody else has a case for the next few weeks, I'll be grateful to hear. But in the meantime, Aaron and Amrita are going to tell us about this patient. So over to you.
Hi everyone, I'm Aaron. I'm one of the endocrine SHOs at Charing Cross, and I'll be doing a short presentation alongside Amrita, who's one of the renal registrars here as well. Fair warning, we do apologise, this isn't an endocrine case, but it was an interesting case we had on the ward recently that we thought would be useful to do some teaching around. So just crack on. So our case was a 67-year-old woman of Afro-Caribbean descent who was referred in by her GP with ankle swelling and shortness of breath, particularly on exertion. So the symptoms have been going on for about a month. In terms of the ankle swelling, she found that it often spread to the knees and was mainly worse when she was standing up. There was some improvement to the symptoms when she was lying down. The shortness of breath, as we mentioned, was mainly on exertion. She was finding it hard to perform her daily activities, so mainly walking up and down the stairs in her home. She didn't have any history of P&D, orthopnea, or any chest pain on presentation, but she did describe an occasional dry cough, but no wheeze associated with that. She hadn't had any recent fevers. So her GP had basically performed some investigations for these symptoms and found her BMP was raised just over 1,500, so referred into hospital for assessment. So she's a lady without any past medical history, doesn't have any regular medications that she takes. Her mother was diagnosed with heart failure at the age of 79, but nothing else significant on her family history. She lived alone and was very much independent, was a non-smoker, only very occasionally drank alcohol, and she worked in the National Gallery. So she mainly noticed the symptoms because her shift pattern had changed. She was asked to stand a bit more frequently and noticed the ankle swelling. So in ED, on examination, she had a normal respiratory rate. She was saturating well at 98%. She had some good air entry bilaterally, but just some mild crepitations at both bases. Her capillary refill time was fine, and she only had a very mild tachycardia. There was this new pansystolic murmur that hadn't been picked up before. She had peripheral edema bilaterally to the level of the knees, and her abdomen was soft and non-tender. She had an ECG and ED, which was normal sinus rhythm. So she had some blood tests initially in ED, and I've shown them here. And although I haven't shown the normal ranges, we're just wondering if anyone could point out anything drastically abnormal that might explain this.
Just while people are thinking, so the reason the GP referred was not because the patient was unwell, because of a number. Is that correct?
Yeah, so her symptoms had, as I mentioned, just gradually been progressing over the past month, but she was still very much stable. But yeah, it's just the raised BMP that she was actually referred in.
Right, common audience, look at these numbers. Someone say something.
Raised lymphocytes?
2.3. Anything else? Nice. Who was that?
Rachel, one of the other ones.
Okay. Right. Okay. And what about the cholesterol and the D-dimer and the BMP?
BMP is high.
Thank you, Bonnie. Ray, yeah. Okay. And the cholesterol's, not great, is it? 9.8. I mean, that's and Sarah's looking at the albumin, yeah. And the protein is 44, total protein. Okay.
Cool. So yeah, we basically outlined, I think, similarly the main ones you guys highlighted. So her protein was very much low, her albumin was also low. She had a raised cholesterol, which seemed mainly LDL related, had a raised D-dimer of about 3,000 and a raised BMP. Although we just wanted to mention that although the protein and albumin was low, her general renal function seemed like it was pretty stable. So just given the presence of the raised D-dimer, the raised BMP and her symptoms, in ED she actually had a chest X-ray and a CTA which were reported together, which showed no filling defects in any of the pulmonary arteries, which would indicate a PE. But there was this small pericardial effusion, as well as some small pleural effusions and some trace in the horizontal fissure. So the findings in general seemed in keeping with fluid overload from a possible diagnosis of heart failure, but no PE.
But the lungs were clear.
Yeah, so on examination, all that was picked up was the small crepitations of both patients.
But no like frank pulmonary edema, because that's quite a little BMP.
No frank pulmonary edema. So in terms of the initial impression, the patient was initially treated as a heart failure type patient. So he was given furosemide, diuresis there, was referred for an inpatient echocardiogram. We flagged her up to the cardiology team for review. There was strict monitoring of her fluid balance, and she was fluid restricted. She was weighed on a daily basis, had a troponin added onto her initial bloods, just in case there was an acute event which might have preceded all this. And also we sent off a urine PCR, given the low albumin and the low protein in the blood. So her troponin add-on actually came back at 175. So we then did a repeat one, which came back at 254. The case was then discussed with the cardiology registrar, who advised to load or adapt for the time being and perform some serial ECGs to see if there are any dynamic changes. So the serial ECG showed no dynamic changes. She then had a further trop of 145, so it was coming down nicely. We managed to expedite her inpatient echocardiogram, which showed, although there was no dynamic changes on that, it showed that she had this concentric left ventricular hypertrophy, but there was generally good systolic function in both ventricles. And again, it picked up the small pericardial effusion that was picked up previously. So the patient was reviewed by the cardiology team, who felt, given the investigations, it was potentially heart failure with a preserved ejection fraction, but then there was this left ventricular hypertrophy, which we weren't sure what was causing that. However, her symptoms were improving on furosemide. Similarly, because her history and ECGs weren't in keeping with a possible diagnosis of ACS, we were told we could stop her dual antiplatelet therapy. And the cardiology team were going to see her in the outpatient clinic and also perform a cardiac MRI just to look at things in a bit more detail. But there was this very low albumin that they were a bit concerned about. So we then did a further urinalysis, which showed 3+ in her protein, as well as a urine PCR, I think it's actually urine ACR of 401. So just given those findings, we wondered what people thought might be going on.
Can I just ask about the urine PCR and sending it off? Because I've noticed recently that when you send any chemistry on the urine, because they put boric acid into the tube, it gets chucked every time. How did you manage to get a urine ACR, that isn't it, protein creatinine ratio? You find a white tube. Anyone else noticed this? We can't get urine chemistry because the sterilins have all been removed. I can't find a sterilin anywhere in the hospital. They're all red top. Am I making this up? Has anyone else noticed this?
This was the third attempt we got to get the urine PCR. So the first couple had been disposed of.
Okay. It's a real problem because what's happened is microbiology have gone around and swapped all the white top tubes for red top boric acid tubes for MSU for culture. Great, but we can't do urinary protein or creatinine or sodium for that matter. Anyway, thoughts, everybody. I'll stop whinging. Yes, Katie. So I think, well, I've been asking around, and it seems that the sterilins that we always have had for the last 50 years have been withdrawn because microbiology don't want those big tubes anymore, and they've been banned. And so they've gone around and removed them all. And so there aren't any, and they've put these red top tubes, not thinking about the chemistry department. See, this is microbiology has gone around removing all the tubes. They're not available. And I went down to chemistry, and they don't order, of course, they just receive the tubes. So ordering is the problem. Ordering, being told to stop ordering the white top tubes, I'm afraid. So they're ordering some new white, no, you can't, because the yellow top tube has got a bit of gel in it, which separates off the serum. Yes, I've informed Tricia, and Tricia's on the case. The GPs have solved it now. We need to get the same tubes as GPs, but it's a problem. And let's move on. Sorry, guys. I'm just deliberately delaying until people can tell us about their thoughts. Because that protein creatinine ratio or albumin, is that an ACR?
It was meant to be ACR.
Okay.
PCR was meant to be.
So there's one thought in the chat. nephrotic syndrome, which did you tell us her blood pressure?
I didn't, but I must admit I'm not sure what it was off the top of my head. I think it was normal. It wasn't anything scary.
And then Katie wants to know if there's any blood in the urine microscopy.
There wasn't any blood. It was just protein.
Okay, so Katie's wondering if it's nephritic rather than nephrotic, I think. If it's protein and no blood, are we all going to agree with Safar that this is nephrotic syndrome? It is a very low albumin, actually, don't we? Yeah. And then liver function is the other cause of a low albumin. So we need to just think for a second, has she got any synthetic? So is her clotting normal?
Her clotting was normal, and her liver function was all absolutely normal. Yeah.
Yeah.
So I can tell you that
Yeah.
Safar was correct, and she did indeed have nephrotic syndrome. So nephrotic syndrome is a triad of three different things: hypoalbuminemia, where you get an albumin level less than 30, proteinuria, and what we consider nephrotic range proteinuria would be a 24-hour urine collection where you get more than 3 grams of protein, or more commonly we do a spot urine PCR, and it would be more than 300 to 350, and they also get edema, and it's also associated with hyperlipidemia. And just going back to basics, essentially nephrotic syndrome is caused by a pathological injury to the glomerulus, which is one of the filtering units of the kidney. And essentially it causes a problem with the glomerular filtration barrier. So in a normal working glomerulus, plasma proteins remain within the circulation because of this filtration barrier, where you have a normal endothelial cell membrane, a normal glomerular basement membrane, and normal podocyte foot processes. But when there is damage to this glomerular filtration barrier, these plasma proteins can cross and pass into the urine. And how do patients present? So commonly with non-specific symptoms of fluid overload, so they get leg swelling, puffy eyelids, abdominal swelling, can be breathless from fluid overload, and they can occasionally complain of foamy urine because of proteinuria. They get weight gain because of fluid retention, and often they're quite tired as well. So what I would like everyone to do now is to log into slido.com and enter the code 555045, and you're going to give me your thoughts on the complications, causes, and treatment of nephrotic syndrome. Prof. Aaron, can you see that? Is that working well?
Yeah, I can see a QR code even, but I'm gonna, let's see if I can get there.
So I'm not going to show the results yet until you've all had a few minutes to type your thoughts in, and you can enter as many as you like. We've got 4 so far that have joined. I'll give you a few more minutes until a few more of you have joined.
It seems like a long time, but you've got to give people, you've got to log in and so on.
Yeah.
So give us a few more seconds.
I'll give you 30 more seconds. Okay, brilliant. Thank you so much for everyone for participating. So we'll go through them. So a few people have put in VTE and thromboembolism. So absolutely, it's one of the main complications of nephrotic syndrome that we worry about, because you get loss of antithrombin 3 and protein C in the urine, which puts people at higher risk of thrombosis. And in particular, they're also prone to renal vein thrombosis, where it can present with flank pain and hematuria, or just rise in the creatinine. And the way that you would diagnose that is with a CT angiogram. So yeah, up to the risk factor for VTE in patients with nephrotic syndrome is 10 times that of the general population, and up to 10% of people with nephrotic syndrome have thrombosis. So very important complication to look out for. And also the risk of thrombosis is also associated with the serum albumin level, and also what is the underlying condition that's driving the nephrotic syndrome. So we'll talk about that a bit later. So hyperlipidemia, absolutely. So the reason that people get hyperlipidemia with nephrotic syndrome is because they've got this massive urinary loss of albumin. So the liver goes into overdrive to produce albumin, and it also increases the production of other proteins, including lipids. Someone's put gram-negative sepsis. And yes, with nephrotic syndrome, they're also much higher risk of infections, as a lot of you have got there, which is excellent. So you get loss of urinary immunoglobulins and complement factors, and so it puts people at much higher risk of infection, including of encapsulated organisms. So sepsis and infections is also a very common complication that you need to be aware of. And I'll take a look through a few others. Heart failure, not so common. It can be one of the things that occasionally people think a patient has got heart failure when actually a urine hasn't been dipped. Hypervolemia, absolutely. If people are aggressively diuresed, that can lead to hypervolemia. DVT and PEs were mentioned. Peripheral edema, yep. So I wouldn't call that a complication. I'd say that that's one of the triad, one of the defining features of nephrotic syndrome. Hypercoagulability, absolutely. High LDL. Immunosuppression. So again, I wouldn't say that's a complication, but it's one of the treatments that's the particular causes of nephrotic syndrome. People are given immunosuppression. CKD, absolutely. So with some causes of nephrotic syndrome, people do get progressive renal dysfunction. So yeah, well done everyone. You've got the main ones that I wanted you to. So now I want you to think about what possible causes of nephrotic syndrome you can think of. So you can put in as many as you like. And the way to think about this is there are either primary renal conditions causing nephrotic syndrome or systemic diseases causing nephrotic syndrome. And I'm hoping you get at least 7 or 8 different causes. I'll give you 60 more seconds to get your answers in. Okay. Brilliant. So we've got a big selection here. So diabetes, absolutely. Diabetes can absolutely cause nephrotic syndrome, one of the most common systemic diseases that causes nephrotic syndrome. Drugs, absolutely. So you can get things like non-steroidal anti-inflammatory drugs, bisphosphonates, heroin can also cause nephrotic syndrome. Lupus, absolutely, can cause a membranous nephropathy. Amyloidosis, primary FSGS, membranous nephropathy, minimal change. So someone's put in, so I just want to pick out a few that aren't causes. So IgA nephropathy, occasionally you can get proteinuria, but it tends to cause more of a nephritic picture than a nephrotic syndrome. Let me see if there's any others that aren't. So renal cell cancer, absolutely, you can get a malignancy driving a nephrotic syndrome. Sickle anemia. Yeah, so everything else on that word cloud, these can all cause nephrotic syndrome. So well done, everybody. So then the last thing is I want you, for this patient that we have presented, we've now decided that she's got nephrotic syndrome because she has this triad. She has edema, a low albumin, and significant nephrotic range proteinuria, as well as hyperlipidemia. So what investigations would you want to do for her? And I'm expecting at least 10 different things. And you can put in as many as you like.
Can you tell how many people have answered it at this point?
Yes, I can. I can see that there are 8 different answers, but I'm going to give you another 60 seconds. Okay, so let's see what you guys have put. So I can see renal biopsy is a big one that people have put, and absolutely to get a definitive diagnosis for what's causing that glomerular injury, a renal biopsy is what will give you your definitive answer. but you don't necessarily always need to do a renal biopsy. For example, if someone who's got long-standing diabetes for 20 years, they've got advanced retinopathy and neuropathy, and they've become nephrotic, you can be pretty convinced that diabetes is the cause of the nephrotic syndrome. So in that situation, you wouldn't typically do a biopsy, but usually, yes, a biopsy is key. Someone's put ultrasound scan, absolutely. So we want to do an ultrasound scan of the kidneys, look at the size, the shape, make sure there's no obstruction, look for any evidence of any scarring. HbA1c, very important to diagnose diabetes, one of the most common causes. Someone's put investigation for the first time, urine dip. So hopefully you will have got your urine dip prior to making your diagnosis of nephrotic syndrome. And then autoimmune screen. So we'll come to that. So often people want to send a full, what we call a full renal screen, but actually there are some tests which wouldn't present with nephrotic syndrome, which is part of the so-called renal screen, and we can go through that in a moment. The 24-hour urine people have put in. So typically we don't tend to do those anymore. We would just do a spot urine PCR, which would give us our diagnosis. Anti-PLA2R, absolutely. So that would give the patients who've got anti-PLA2R associated membranous nephropathy. Very important to send that off. Echocardiogram, absolutely. So patients who you're concerned that this might be a cardiac cause, it's important to get an echocardiogram. Myeloma screen, yes. Drug history, absolutely, because we said that several drugs can cause nephrotic syndrome. Tumor markers, definitely, because malignancy can also cause nephrotic syndrome. So depending on the age of the patient and their history, you'd want to do a potential workup for a malignancy as well if you thought that was likely. Antibody screen, we'll go to that in a second. CT cap, yep. So if you were worried that this was a malignancy, then potentially CT cap, potentially PSA, mammography, endoscopy, depending on what the clinical picture was. Fasting glucose, urine PCR, absolutely. Viral screen, definitely. ANA, yeah, looking for evidence of lupus. Protein electrophoresis, absolutely looking for evidence of myeloma or amyloidosis. Hepatitis serology, myeloma screen, urine benzoate protein. ANA, anti-double-stranded DNA, yes, looking for lupus. Chest X-ray, definitely looking for any potential evidence of malignancy or fluid overload. HIV, yes. CT-KUB, usually you'd get enough information from an ultrasound that you wouldn't normally need to do a CT. And immunoglobulins, yeah. So yeah, well done, everybody. So I'm just going to now share the presentation again, and we'll just briefly go through that. So the main complications I want you to take away from this is the increased risk of thrombosis, increased risk of infection, and the risk of acute kidney injury, as well as chronic kidney disease and people progressing to end-stage kidney disease. And these are the most common causes of nephrotic syndrome. So we split it into systemic diseases and primary renal causes. And so systemic diseases, most common is diabetes, lupus, amyloidosis, as well as infections, as well as malignancy. And then there are primary renal causes, minimal change disease, FSGS, and membranous nephropathy. And the reason they've got these names is because it's what the histological pattern is. And we'll go through that in a moment. So in terms of your diagnostic evaluation for nephrotic syndrome, you want to do your baseline test, which is patient history, most important, urinalysis, because you want to see, is it blood or is it blood and protein? And then you typically, for someone with nephrotic syndrome, they'd have 3 to 4 plus of protein on their urine dipstick, serum creatinine, which can often be normal, serum albumin, which we'd expect to be low in nephrotic syndrome, lipid profile, CRP, which can be raised in certain conditions if someone's got a chronic inflammatory condition like causing AA amyloidosis. A CRP would be high, and a bone profile is also important because a raised calcium can either be an indication of myeloma or malignancy. And then in particular, these are the investigations that you would do for nephrotic syndrome. So you want to look at if it's appropriate for that patient. So you want to do a screen for lupus, so an ANA, double-stranded DNA and complement, look for diabetes, for HbA1c, look for any evidence of amyloidosis or myeloma with serum proteinophoresis, serum free light chain, serum Beta-Jones protein. And you want to do a virology screen, so Hep B surface antigen, Hep C antibody, and HIV, and antiplator antibodies. And then very important to get an ultrasound of the kidneys. And like I said, renal biopsy is the definitive diagnosis, but like I said, not always necessary. So in terms of the treatment of nephrotic syndrome, these are the general management principles. You want to make sure people are on an ACE inhibitor or an ARB, and that's to reduce proteinuria by reducing glomerular hemodynamic pressure and also reducing blood pressure. They will need diuretics, and often they can be resistant to oral loop diuretics, so occasionally you need to add in thiazide diuretics, or they may need to be admitted for IV diuresis, and occasionally their blood pressure needs to be supported with albumin. Often we give 20% human albumin solution, 100 mils twice daily if they do have hypotension. Really important that they're salt and fluid restricted, so less than 2 grams salt per day, and fluid restriction will depend on their size and how overloaded they are. Really important to monitor how well they're diuresing with daily weights. Typically you're aiming for losing 1/2 to 1 kilo per day, and you don't want to over diurese them because you can make them at risk of hypovolemia and AKI. Statins occasionally used for hyperlipidemia, but the evidence of efficacy in nephrotic syndrome is limited. Typically, if they had a cholesterol more than 10, we would typically add in statins. And then thromboprophylaxis. So this is very important because as you now are all aware, thrombosis is one of the major risk factors, or one of the major complications of nephrotic syndrome. And the decision about what thromboprophylaxis to give is based on what their serum albumin is and also what the underlying cause of nephrotic syndrome. So
if you give someone albumin individually, does that just pee it out?
So potentially, but it is commonly what we do on the renal wards. I don't know necessarily how much evidence there is behind it, but if we are struggling to diurese people, then we do give them HAS as well. But yes, you're absolutely right. They do have huge losses of urinary albumin. And then going on to thromboprophylaxis. So typically our decision about what to use is based on the serum albumin. So typically if the serum albumin is between 20 and 30, we would give aspirin, 75 milligrams, but that would also depend on whether or not when they were going to have their renal biopsy, because we want them to be off aspirin for 5 days before. So typically that would only be started after. If their serum albumin is less than 20, we would give them either prophylactic enoxaparin or warfarin. And we have a higher threshold for giving anticoagulation in patients with membranous nephropathy because we know they're at much higher risk of thrombosis. So the threshold for giving them anticoagulation would be a serum albumin of less than 25. These patients are at much higher risk of cardiovascular disease, so really important to give them lifestyle advice, including smoking cessation. And as we mentioned, they're at higher risk of sepsis from encapsulated bacterial organisms, so important that they're vaccinated against pneumococcus and that they have their influenza vaccinations as well. And then there are disease-specific treatments. So the primary renal diseases, most commonly minimal change, FSGS and membranous, typically are treated with immunosuppression. And these can be quite toxic treatments. So minimal change disease is, the reason it's called that is because on light microscopy, you typically see normal looking glomeruli, and it's only on electron microscopy that you see this effacement of the podocytes. And typically, or classically, people are treated with 1 milligram per kilo of prednisolone up to a max dose of 60 milligrams for 4 to 16 weeks until they reach remission, and then it's tapered down over 6 months. And as you can imagine, that is a very high amount of steroid burden that they are getting. So tacrolimus is now commonly used, although it can be slower to induce remission, but also very effective. In patients who have frequent relapsing disease or are steroid dependent, then they can occasionally be treated with cyclophosphamide as well. Minimal change is most commonly in children, but can also present in adults. Then an FSGS, so is when you get its focal segmental glomerular sclerosis, you see scarring of the glomerular tuft. So this can either be primary or genetic or secondary. So it can be secondary to several different conditions, including obesity, HIV, heroin, bisphosphonates. So lots of different secondary causes, and usually that's because of a hyperfiltration injury to the glomerulus. Primary FSGS, you would typically treat with prednisolone or potentially tacrolimus. And then finally, membranous nephropathy. So this has classical features on histopathology. A third of patients with membranous nephropathy do spontaneously remit and go into remission themselves. So often patients can be treated for 3 to 6 months conservatively and just monitoring them to see if they go into spontaneous remission. However, if they're at higher risk, and we consider those high risk, those with more heavy proteinuria or, for example, very high anti-coagulative antibodies, then we would typically treat them earlier with either rituximab or tacrolimus. And if they were very high risk, if they had severe life-threatening complications from nephrotic syndrome, then typically we treat them with a Ponticelli regimen where you get 6 months alternating cyclophosphamide and steroids. And these conditions often can relapse. And so patients with nephrotic syndrome often have, with the primary renal disease causing it, often have a heavy immunosuppression burden. So that's something just to be aware of if you see anyone coming in with minimal change FSGS membranous as part of their history. So really the takeaway points from just this teaching about nephrotic syndrome: if the patient presents with fluid overload, so important to check the albumin and dip the urine, and can easily be mistaken for cardiac or liver disease. And it's only when someone thinks to dip the urine that it's picked up. You're now all aware of common complications in nephrotic syndrome, particularly thrombosis and infection. And if you do suspect nephrotic syndrome, do contact the renal team as soon as possible, because most commonly patients will need a renal biopsy and immunosuppression. So really important to have those baseline investigations at hand when you're referring, in particular the serum albumin, the serum creatinine, and the urine PCR.
That was really excellent. That was a fantastic.
So we have a bit more to go.
Oh, really?
So we have a bit more about this particular patient. So Aaron's now going to tell you what happened next.
Like Marvel.
So our story continues. So based on the urine PCR, we spoke to the renal team who, as we talked about, suspected diagnosis of nephrotic syndrome as well. So they reviewed her and planned to have her as an outpatient and organise a renal biopsy to follow up with her. Advise us to undertake some ultrasound of both of their kidneys just prior to being discharged, to give them a bit more information just prior to the biopsy. But as Amrita mentioned, because these patients are quite prone to clotting, they also mentioned that we should discharge them with prophylactic enoxaparin just upon discharge, which we have to continue. So it's an interesting but unfortunate story. So she had the ultrasound of both her kidneys, which showed parenchymal changes possibly in keeping with nephrotic syndrome. On a background of this, it was also picked up that she had a 3.1 centimetre exophytic soft tissue mass in the upper pole of her left kidney, which was suspicious for a potential malignancy. So we liaised further with the renal team, who asked us to do a further MRI, which just confirmed that there was this tumour in the her left kidney, which was in keeping with a possible renal cell carcinoma. So we were then informed that this nephrotic syndrome could likely be a paraneoplastic phenomenon from the renal cell cancer that she could have. So we were asked to liaise urgently with the urology team. They organised some further scans and discussed her in the urology MDT. And from their last MDT note, it looks like they're planning to perform a left robotic partial nephrectomy and then biopsy the surrounding tissue to study things in a bit more detail.
So she was seen in renal outpatient clinic this week, and some more of her investigations were back. So she had a very high lambda serum free light chain level of 213 and a low capital lambda ratio of 0.08. We're still waiting for her Bent-Jones protein and serum protein electrophoresis. All of her other viral and autoimmune serology was negative, but she'd also had an outpatient cardiac MRI as per the cardiologist, and those showed features in keeping with cardiac amyloidosis, in particular AL amyloid. So the impression for this lady is that she likely has AL lambda amyloid affecting the heart and the kidneys, plus a likely renal cell carcinoma as parallel pathology. So the plan for her is she's going to have a partial nephrectomy for cancer removal and also study of the surrounding kidney tissue to diagnose what is causing her nephrotic syndrome. And they would do light chain staining to see if there was evidence of lambda restriction and also Congo red, where you'd get this apple green birefringence under polarized light. She did indeed have amyloidosis. She's being referred to the hematologist, and the monoclonal gammopathy of renal significance, MPT, and hematology, cardiology, and neurology follow-up is in place. So I thought I'd stop there for you to ask any questions either about nephrotic syndrome or about the case. I can see that there's one question already. Could the nephrotic syndrome be part of a narcoleptic syndrome of query RCC? So absolutely. So this RCC could be driving a secondary membranous picture and causing the nephrotic syndrome. But I think likely we think as well that she's got AL amyloidosis.
She's unlikely to have both AL, unlucky to have AL amyloid and RCC. They're not.
Absolutely.
That's very unlucky.
Very unlucky. So we'll see what the biopsy ends up showing.
I mean, was the echo? Well, the echo normally picks up AL amyloid in the heart. Did they say anything?
The echo mainly picked up this left ventricular hypertrophy, which is why they then organised the cardiac MRI, and that was the main thing. I think at that point they might have been already suspected diagnosis. The MRI was really helpful towards that.
Right.
Hi, Amrita, Aaron, Karim. It's Gulam here, one of the pulmonary hypertension consultants at Hammersmith. Excellent presentation. Just some comments, really. Now that I've seen the result of the cardiac MR, actually going back to the presentation, when you describe the echo features of presentation with a pericardial effusion and then the X-ray changes that were compatible with a high left atrial pressure, you could tell from that point there was something more than just low albumin levels causing edema as the problem here. So we know that the coronary sinuses drain into the right atrium. So if you've got pericardial effusion, by definition, you've got high right atrial pressure, which isn't going to be caused by hypoalbuminemia. The same goes really for the interstitial changes that you see at imaging. So amyloid's a lovely way to pull all this together in the context, of the diagnosis of nephrotic syndrome, and it really does explain those echocardiographic features. Another comment as well is that when you presented the BMP and the D-dimer, I just wondered how hard you actually looked for more distal thromboembolic disease in this case as an independent driver of right heart failure, for example, the chronic thromboembolic disease in the background here. So VQ scanning and the likes.
So I don't think that was done.
No, I think the most we did was the CTPA, but no VQ scanning. No.
Excellent. Excellent talk. Yeah, really great case. Really well put together.
I agree. And would you do a VQ scan? I mean, it's always used with hindsight, but do you think that would be more helpful?
I think it's difficult when you see features of high right atrial pressure, and then you know that the condition is, very heavily associated with venous thrombosis, and the VQ scans are probably 90-odd% sensitive as opposed to CTPAs, which are 50 to 60% for picking up distal thromboembolic disease. When you've got an index of suspicion like this, I would probably, when she's dry, like to get a VQ scan just to check, because that will influence the anticoagulation decisions.
And can I ask you about prognosis in amyloid of the heart?
So typically the prognosis is quite poor if someone's got cardiac amyloidosis. Often, depending on the extent of the cardiac extent of involvement, it tends to be pretty poor. But these patients normally get referred to the National Amyloidosis Centre and followed up and investigated and treated there. But my understanding is poor if there's cardiac involvement.
Thank you. Any other questions or points? That was an ideal case really to educate us all on several factors. So thank you very much for doing that.
No problem. I think there's a few more questions in the chat. So Ed Lewis has asked me, what are the contraindications, things to consider prior to renal biopsy, e.g. DAPT, etc. So absolutely. So the most important complication following a renal biopsy is bleeding. So typically what we quote is 1% risk of needing a blood transfusion and 1 in 1,000 risk of needing a further procedure to stop the bleeding. For example, them needing IR embolization, and 1 in 3,000 of bleeding being so bad they might need a nephrectomy. So that's the main thing that we consent people for, and so we We do want them to be off antiplatelet agents for 5 to 7 days beforehand, and to have a normal clotting. So those are the main things to consider. And also, if a patient, for example, had a solitary kidney, then we'd have to have a very high threshold to come to the biopsy because of the potential risk of complication if that was to happen, of them losing their kidney. So we do have to consider several things when we're making that decision about biopsying someone. If they're just on enoxaparin, then you just need to hold it the day before. And so typically these patients, we wouldn't put them on asthma or anything like that until they've had their biopsy and we know what the diagnosis is. We'd normally just have them on prophylactic enoxaparin. And someone else put, when investigating proteinuria, what is the use of ACR compared to PCR? So ACR, the albumin-creatinine ratio, picks up much more subtle levels of albuminuria. So we usually use ACR if we were trying to look for conditions like diabetic nephropathy. You wanted to pick up early that they've got potential diabetic nephropathy. With nephrotic syndrome, they have really heavy proteinuria. So typically for those patients, we would send a urine PCR because that would tell us if they've got nephrotic range proteinuria more than 300 to 350. But if you were, for example, seeing someone as an outpatient CKD, you typically send off a urine ACR because it can pick up lower levels of proteinuria.
And are the 24-hour collections history now?
Yes. So the spot urine PCRs are just as good as the 24-hour urine collections, and no one ever does the urine collections correctly anyway. It's very difficult to do that over 24 hours.